Hey everyone, and welcome to One Size Doesn't Fit All, Nutrition in a New Era. My name is Shelby Luebbert, and I'm so glad to see some of you guys as familiar faces, and I'm an adult living with CF in St. Louis, Missouri. I will be moderating this session tonight, and I will be introducing our other speakers in just a moment, but before I do have a few housekeeping items. This session is being recorded and will be available after the event on the CF Foundation YouTube channel. You will be notified by email once session recordings are available. After our presentation, we will take a quick 5-minute break, and then we will be hosting a 45-minute extended Q&A with today's speakers. So please hold all of your questions until the end. We won't be able to answer questions about individual diagnosis, treatment plans, and we encourage you to use the information that you learned today to go to your care team. The extended Q&A will take place in the same room at 9:15 Eastern Time. The Q&A portion of this program will not be recorded, and you are welcome to submit questions in the meantime in the Q&A tab of this session chat. Please make sure you are in the session chat to be able to converse with others in this session as well, versus the event chat that is conference-wide. If you experience any technology problems during the session, please visit the help desk on the left side of your screen. We also want to remind everyone of our community guidelines, so please be kind, open-minded, and respectful of everyone's opinions and life experiences, and please do not ask or give medical advice. If you need staff support at any time or want to report a violation, we also encourage you to visit the help desk. So, let's get started. I will be serving as the moderator tonight, and I'm joined by Janeil Whitworth, an adult with CF, Emma Lyons, a psychologist, Kelly Stewart, a dietitian, and Senthil Sankararaman, a pediatric gastroenterologist. The goal of this session is to be completely inclusive of race, sexuality, and gender. We are all aware that some research is not completely inclusive as of yet, but all aims are to be open and inclusive of one another's journeys within the presentations. We will welcome all questions that we are able to tackle. This journey takes a village, and compassion goes a long way in things, so please be kind. We are going to start with each panelist introducing themselves and their work in a 5 to 10 minute presentation, and then we will be giving more insight into my reasonings as well on why I'm so passionate on this subject before we jump into the panel discussion to dive deeper into nutrition topics. I want to give a big heads up that due to the restraints of Hopin, you will probably have to go to full screen mode on the video part so that you can see the presentation slides. It's unfortunately making things super small, and we realize this on our run through. And with laptops, it's even tinier. So we apologize in advance. If you hover over our screen, it should show you the outline and you can hit full screen. With that said, Senthil, I'd like to turn it over to you first.
Thank you so much, Shelby, for your kind introduction. Sorry. Good evening, everyone. It's really a big honor, and I'm so excited to be here and meeting you virtually. My name is Senthil Sankararaman. I'm a pediatric gastroenterologist. So I participate in Pediatric CF Center at Rainbow Babies and Children's Hospital. This is my incredible team. This picture was taken in NACFC at Philly last year. And one fun fact about me, so my first and last name, that's so unique. There is no second person in among the 1 billion population we have. It's just, I'm the only one with this name. So with this, next slide, please. I have no disclosures pertinent to this presentation. Next one, please. So my topic of interest is undernutrition. So I would like to kind of get your attention to the third column, which says nutrition or nutrient imbalance. So let's start with what is undernutrition. So when the overall nutrient intake is less than what we need, what our body requires, then we say that a state of undernutrition prevails. So this slide is adapted from a society called ASPEN. ASPEN is an acronym. It stands for American Society of Parental and Enteral Nutrition, who kind of oversees the malnutrition related management and gives recommendations to other clinicians. So this slide is not pertinent just to people with CF. This is for everyone. So here basically the first column kind of like broadly classifies how one person can develop malnutrition, either related to their underlying illness, or it could be totally something different, or could be on the top some inflammation component can also predispose to malnutrition. In people with CF, oftentimes it's the second and third cause, which is either CF related or CF related inflammation, but any like combination of these factors could also play a role. So then what's the mechanism? Again, like three big categories or three big buckets, we can say. One is overall reduced intake. This could be due to any cause. The second cause is decreased absorption of nutrients. And then the third one is increased need, or what we call hypermetabolism or catabolism. So again, like all three causes, all three factors can kind of like act together in predisposing a person towards malnutrition. So then the next question comes, so why we need to worry about undernutrition or malnutrition? So basically both terms are used very synonymously. They kind of like mean the same. So oftentimes I tell my patients, just imagine like our expenditure is like more than the income. So we then get into trouble. The same thing, our body works in the same way. When our nutrient intake is less, then it starts using the available nutrients in our body, which are basically fat and proteins. So it starts with fat, and then after some time, then it starts utilizing all the proteins we have, which means the protein in the muscle, which is the major reserve for proteins, and the protein in the bones kind of go low. So we develop muscle weakness, poor bone health, things like that. And then also we know that to fight infections, we need the protein substance called antibodies or immunoglobulins. So that goes low, so which increases the risk of infections. And then in addition, so undernutrition applies to all populations, but the population or the children or the younger children, I would say infants, toddlers, and preschool children are the one who get more affected by undernutrition, because they are growing so fast and they're also very active, and so resulting in developmental delay. In other words, the undernutrition can lead to poor neurological outcome. Say if the patient goes for any surgery or any procedure, it could also delay healing. It could also prolong the hospitalization. So for these reasons, undernutrition, whenever we find, we would like to kind of like diagnose early and then manage aggressively. Next, yeah. So this one, again, just kind of follow up from the previous slide. Here, the three big categories are highlighted in the Venn diagram, and you could see that the overlap, like the factors could act together in predisposing patients towards undernutrition. And I'm sorry, I apologize. This is a busy slide, but very important slide. And many of you may have questions regarding the conditions. So if you go ahead and take a snapshot, we can discuss more in detail during the Q&A section. Here, I have included both CF related or CF focused factors, as well as non-CF related factors as well, resulting in decreased intake and undernutrition. Next slide, please. So then the question comes, so what we know, what is the link between nutritional status and respiratory function in CF? So when did we start recognizing the importance of nutrition in CF? So this is a landmark study, or a sentinel study, what we call. So this was very elegantly done. It was published in 1988. So this study, the investigators compared two big centers in North America. So they took Boston and then they took Toronto. And both the centers are very similar. They included closer to 500 patients in each center. And the distribution age-wise, gender, sex-wise, kind of both centers very equal. And at the time, I have to remind our audience that the standard of care at the time in nutritional management was high calorie and low fat diet. And the reason for low fat diet was the enzymes available at the time had a lot of GI intolerance and side effects. So we couldn't optimize the enzyme management. So on the other hand, the fat was, the recommendation for fat was much lower across in US. Whereas Toronto, they adopted a different approach where they still kind of like optimize the enzymes and increase the fat. Here you could see that the big difference in survival. So this is done in, I told you, like 1988. So before that time frame, the average median means average or in the middle number. So it was 30 years in Toronto compared to 21 years in Boston. This is where all the clinicians and all the researchers were like kind of like started realizing the importance of nutrition in the management of CF. So the big difference between the centers at the time, like in this patient population, was aggressive nutritional management, as I said, and also patients in Toronto weighed heavier and then also were taller compared to patients in Boston. Next slide, please. So since then, many investigators started doing similar research, and again shown that both the nutritional status and respiratory status are very closely interlinked. So just want of time, I just included another landmark study. This was published in 2013. So here the data was taken from CF registry, so which means people with CF across all centers in US. So about 3,000 patients. And here they clearly demonstrated that a greater weight at 4 years of age was associated and correlated with better outcomes through the next 10 years. So again, kind of like it reiterates the same notion that better nutritional status corresponds to better respiratory status. And the idea behind that is, especially when you attain a better nutritional status at much younger age, your chances of getting taller is higher, getting heavier is higher, which means that the development and function of lung is much better. So resulting in decreased hospitalizations and decreased admissions, having better outcome in cystic fibrosis. Next slide, please. So fast forward, let's see what our latest data. So this data is taken from CF registry. This is 2021 data. The one on the left side includes children between 6 to 19 years. The one on the right side is for adults. So the x-axis means the horizontal axis and the y is the vertical axis. The one on the left side where the red diamonds show, so this is data from the last 20 years comparing median BMI in the x-axis versus FEV1 percentage predicted in the y-axis, where you could see that every year, or for all the plotted years, you could see that it just progressively goes up, and the highest was last year. So the BMI was closer to 65th percentile for children, and then the FEV1 is closer to 100. So we could see that it just progressively keeps on increasing. And then also I want to remind the audience that even before the introduction of modulators, this change has been happening, but it kind of kept on increasing, likely due to the arrival of modulator as well. The same thing we can find in the adults also, a little bit less impressive than in children, but we could see that the progress has been pretty same. And I have to here remind that there is just since the BMI is increasing, the undernutrition proportionately started declining, which is a really great news. Next slide, please. So this is another way of looking at the data. This is again 2021 data. So here we took all the BMI of all children attending the CF, CF centers, and plotted against the FEV1. So here you could see the first one is children, the second one is the bottom one is adults, where you could see that when the BMI percentiles in children and the absolute numbers in adults were lower, their FEV1 is lower. Whereas if you look at the right side of the graphs, you could see that the BMI is higher, which corresponds or correlates with higher FEV1. The correlation is more, again, significant in children, but having said that, even in adults, it correlates really well. And a lot of you may be wondering where that magic number, 50th percentile of BMI in children, 22 and 23 for women and men comes. So this is where our advanced statistical experts and clinicians look at the data, they could run all predictive models and kind of like come up with the cutoff, like which is the best BMI for each age group and each sex, and give us that prediction that, and then we work towards that goal. Next slide, please. So in other words, in a nutshell, we can categorize the CF management into two big pillars. So one pillar is like the management of respiratory function, and the second one is nutritional optimization. They both are very interlinked and also interdependent. In other words, managing one definitely improves the other, and then overall, both improves the outcome. Next slide, please. So once we diagnose undernutrition, then how we go about, what are the next steps? The first two categories are more important, and that's often done at the patient level, like during our clinic visits. So the first step is, like I told you, there are many players, many reasons underlying. So we evaluate for those reasons. And then once we find the reason, then kind of working towards that. For example, if I say the pancreatic enzymes can be optimized for, like the patient had a recent increase in weight gain, then the enzyme doses were low, and then now started having some symptoms, and with progressive weight loss or something like that, we can optimize that, just to kind of to give an example. So working towards the underlying cause is the first step, and at the same time, our dietitian colleagues are also closely involved, and as you all know that, like they can help us devising a personalized nutrition approach, which is like a very specific for that person, taking into the taste preferences, religious beliefs, cultural practices into account. So like the first two steps are, we spend like more time, and we kind of like try to see whether we can improve the nutritional status. And once we exhaust that, or if from the beginning, if the nutritional status needs to be more aggressively managed, we recommend the oral supplements. So the latest registry data says that about 30% roughly among the people with CF will be on oral supplements, are getting oral supplements. And then the last step is the tube feeds, which is closer to 10%. And again, we will be very cognizant the words we use, and then also the interactions with the patient. We never give the impression that tube feeds is like, or even oral supplements is like failure of first two steps, then we are going towards that. So that's kind of the completely opposite approach. A lot of times we quickly move on to the oral supplements or tube feed steps. The reason is the quicker we initiate the intervention, sometimes it helps us to overcome the undernutrition much quicker based on different scenarios. But at the same time, we will spend enough time, we spend more time to make sure patients completely, it's like a more informed approach between the patient and the clinical team. Next slide, please. So again, I want to reinforce that it's patient-centered approach. I just included all the core members present in our CF center, pretty much very similar to all the centers, with the exception of one or two additions are less. So starting with pulmonologists at 12 o'clock in the top, registered dietitian, pharmacist, endocrinologist, physical therapist, gastroenterologist, registered nurse or nurse coordinator, as well as respiratory therapists. Some centers do have behavioral psychologists, occupational therapists, and speech therapists. Their presence is very helpful. But then at least like centers like us, where we don't have it in the center, we have the opportunity to collaborate with them outside the center as needed. Next slide, please. So the core concepts in the management, and again, we can discuss this during our Q&A. So I divide into two aspects. One is patient communication with the patient. So the approach, we know that undernutrition or weight or any discussion surrounding weight is a very sensitive approach. So it's a patient inclusive approach. We never focus on numbers rather than patient focused approach. And then two-way communication, like we just will make sure that we both are in the same page. And with the fast pace, with the clinic, shorter clinic time, things like that, sometimes an important message or important information can be easily kind of like missed. So we'll make sure that like that's not happening. And then also we recommend an intervention, and then we follow very closely, not necessarily with clinic visits. Sometimes we do offer virtual visits or EMR messages with the patients, or phone calls, email, correspondence, things like that. So bottom line is close follow-up to try and kind of like we can move on to the next step if one intervention doesn't work. And then within the team, the core messages are a unified message among the members of the team, so that there is no mixed messages. Even though we speak the same kind of same intervention, sometimes when the delivery of the message could be interpreted a little bit differently. So we'll make sure that that's not the case, and so there is no confusion among the care members in delivering the message. And the last one is a very, very important one, like ourselves, the landscape of nutrition, the landscape of CF, totally not even focused on nutrition. It has been changing so faster. We are keeping ourselves with QI projects, research training, meetings like this, NACFC, and also working closely with the CF community and directly hearing from you as well. Next slide, please. And then to conclude, again, I want to reiterate or reinforce what Helen Keller said about the teamwork. I'm so happy, and I can brag that I'm a CF clinician. I learned so much, and I'm willing to give back. And again, I'll take your questions during the Q&A sections. And thank you again for this opportunity. And passing on to the next speaker. Emma, you're up. Thank you.
Thank you so much. Hi, everyone. My name's Emma Lyons, and I am a pediatric psychologist at Children's Hospital, Colorado. That is a picture of me and my family. I am the one in the shorts overalls with crossed eyes. So I've been working in our Cystic Fibrosis Center here almost 3 years ago, and I have kind of a specialized interest in feeding behaviors and disordered eating and body image concerns in our pediatric CF population, which I'll be talking to you more about today. So as we know, nutrition is a really critical component of CF care. But for some families, the scope of nutritional requirements can often be very stressful. So children with CF are recommended to eat a daily caloric intake of about 120 to 150% of what is usually recommended for children without CF. And this is a lot of food to consume. So some children really don't have any difficulty with this, but there are other children who can be described as picky eaters, meaning that they really don't have an interest in food, or they may eat only a very limited range of foods, or just a limited amount of food. And actually, this is really normal behavior for children in general. But for children with CF, this can produce a lot of stress for families during mealtime and can lead to a lot of conflict around eating and around food. And there are definitely many other underlying medical reasons that children may not show interest in food, which should be addressed and explored by families and medical teams together. But regardless, stressful, negative associations and relationships with food early on can lead to challenges throughout the lifespan for children or for people living with CF. So adolescents and young adults with CF are kind of at a unique risk for experiencing stress associated with eating, weight gain, and body image, largely due to an increased sensitivity to societal and cultural ideals for body shape and size, and due to the focus on weight and nutrition throughout their lives because of CF. So I really became interested in these issues after the approval of Trikafta, when I worked with several adolescents with CF who reported that they were noticing weight gain after starting Trikafta, which made them not really want to take it. And I was hearing these concerns enough among patients in our clinic that I wanted to kind of understand this in a more systematic way and really see if this was a prevalent issue among the adolescents and young adults that we saw, and if it truly was affecting adherence to Trikafta. So we created a questionnaire that assessed self-reported Trikafta adherence, body image, satisfaction and dissatisfaction, and feelings and perceptions about taking Trikafta and changes in any symptoms that were noticed. This questionnaire was given to adolescents and young adults ages 12 to 25 years old who had been prescribed Trikafta for at least 6 months. And I should note that a limitation to this study was that it only included people who were eligible and prescribed Trikafta and did not include people who are not eligible for modulators. So I'm just going to provide you with key highlights of the results of the study. So first, we asked if you noticed any differences since starting to take Trikafta, what have you noticed? And this was a text writing question, and the answers to me were pretty interesting. So weight gain popped up pretty frequently. So weight gain, muscle gain, breathing easier, gaining more weight, changes in mood, weight and lung function, just to name a few. And indeed, what we found was changes in weight were actually the most frequently endorsed change after beginning to take Trikafta, followed by changes in breathing. And that, to me, is pretty interesting because it tells me that adolescents and young adults were noticing weight changes perhaps more so than changes in lung functioning. And on our measures of body dissatisfaction, a majority of the participants actually endorsed wanting to be smaller in body size. So this is the graph on the left. And the graph on the right shows gender differences in body dissatisfaction. So we see here that more adolescents and young adults who identified as female reported wishing to be smaller, whereas more participants who identified as male wished to be larger in body size. So another limitation of this study is that while it did include gender diverse participants, it did not allow them to specify if they identified as gender neutral or non-binary. So then, to understand how body image concerns related to Trikafta adherence, we asked these Likert scale response questions. So the first one up top, my weight and or how I feel about my body affects my decision to take Trikafta as prescribed. We found that 31% of patients reported that weight changes or body image does affect taking Trikafta, but we don't know, in what way. So weight changes were either motivating them to take Trikafta or weight changes were motivating them to not take Trikafta. So we asked the question, I do not want to take Trikafta because it causes me to gain weight. We found that 23% of participants endorsed not wanting to take Trikafta because it caused them to gain weight. And further, the responses to these adherence questions differed significantly on whether adolescents and young adults desired to have a larger or smaller body size. So even though these are relatively small percentages, it still tells us that body image and weight changes are somewhat of a concern in our adolescents and young adults living with CF. And it does have some effect on self-reported adherence. But I do think it's worth mentioning and important to mention that a large percentage of participants who reported weight changes did not report effects on their adherence to Trikafta, meaning that they were noticing weight changes and they were still choosing to take Trikafta. So this study was very preliminary. It was very kind of basic look at these issues, and these concepts really need to be further explored to clarify just how body image and body changes relate to adherence to Trikafta and other parts of CF care for adolescents and young adults. So what can we do about this? We're really going to dive into this more in our upcoming Q&A, but I'll just provide kind of a brief overview. So for care team members, we need to remember that everyone thinks about their body in some way. So positively, negatively, neutrally, we're all thinking about our bodies. So we need to have conversations in clinic that allow for people living with CF to express concerns about their bodies if needed. We also need to think about language. How are we talking about weight gain, nutrition, and eating? Are we labeling changes in weight, food, or eating patterns as good or bad? We first need to be kind of raising awareness about these messages that we send during visits, and then kind of work on shifting our perspectives. And for parents, we also need to be thinking about the messages and behaviors that we send to children about food, eating, and bodies really early on. And that is it. I'll send it off to the next person.
Thank you, Emma. Hi, my name is Kelly Stewart. I'm a dietitian with the University of Utah Adult Cystic Fibrosis team. And I just threw some fun pictures up here. So the top left is my team members. I love alpine climbing on my off time, so that's a photo of me climbing. I also love eating after climbing. So there's a photo of me eating after spending 2 days on the rock wall. And previous to being a dietitian, I actually was a professional baker and a sheep herder. So there are some fun facts. And then we'll just jump right in. Senthil touched on this earlier, that previously in the world of CF, our main concern as dietitians was malnutrition. And then next slide, we had these modulators hit the market. And as everyone knows and hears over and over, that a lot of weight gain was really common for most people when they started the modulators. And one question that I often get asked, and there's new research that I wanted to point out, is that weight gain to the overweight BMI category is actually associated with a higher FEV1. So while there's a lot of concern about weight gain from a cultural and aesthetic standpoint, it actually elicits or is associated with better lung function. But regardless, when patients in our clinic first started gaining weight, the number one question I was asked was, well, shouldn't they lose weight? You know, like this is obviously not a good thing. Go ahead, next slide. And it got me wondering, is dieting really the answer? So I was being pressured by providers and patients to, hey, let's put patients on diets. And I wondered if that was really the answer. So I went and looked at some research. And in fact, weight regain is the typical response to dieting. So this is looking at a study done by Tamaya et al. In 2013. And they did a review of every randomized control trial of diets that included a follow-up of at least 2 years. And that's really important because we need long-term follow-up in nutrition studies to make sense of the data. And so what this slide is depicting is that the dieters in the studies did lose weight between the first 9 to 12 months, but then over the next 2 to 5 years, they gained back all the weight they lost and an additional 2 pounds. So they really had little outcomes to show for their efforts. Whereas the non-dieters, while they didn't dip down initially, they only gained an average of 1 pound. And so again, weight regain is really the typical response. In fact, the data shows that 95% of diets fail. Next slide. So then the question might be, what do you do instead? If you're not going to diet, dieting doesn't work, where do you turn to? And this applies to everybody, whether you're trying to gain weight, lose weight, weight neutral. We want to shift our focus to habits. And this is my favorite study that really powerfully drives home the answer that I found over and over in research. So this graph is from a study utilizing NHANES data, and NHANES stands for the National Health and Nutrition Examination Survey. So this survey has been going on in the US since 1960, and it examines a national representation sample of about 5,000 people each year. What's interesting about this study is that they look at habits in addition to weight. So on the y-axis, we have the hazard ratio for all-cause mortality. You can just think of that as risk of death. And the different bars represent the different BMI categories of healthy, overweight, and obese. And the x-axis represents the amount of healthy habits. And so the 4 healthy habits they looked at in this study were fruit and vegetable intake, tobacco use, exercise, and alcohol intake. And what you can see denoted by the red circle is that among those who practice all 4 healthy habits, BMI effectively stops being a factor that predicts mortality. So in other words, behaviors matter regardless of weight. Next slide. So let's take a different road. Typically in healthcare, we follow the left-hand side of this chart. We work with patients to help them lose weight. If they're trying to lose weight, 95% of the time that doesn't work. Everyone gets frustrated. We're kind of trapped in this pseudo cycle that doesn't actually elicit the health benefits that we associate with losing weight. But if we took a different road depicted on the right-hand side of this graph and we focused on habits, then we could actually elicit the health benefits that we're all looking for. Next slide. You can go ahead and, oh, there we go. Okay, there's a little bit of a delay today. So the point is to focus on habits, that habits really influence health. And the habits that we focus on, particularly in my clinic, are habits of eating, habits of movement, and then the thought habits that we have around eating and movement that drive those behaviors. And again, this is really crucial for everyone, whether you're trying to gain weight, weight neutral, or lose weight, habits really matter. Next slide. But this is really hard because the air we breathe is diet culture. So this picture is a runner in a city, and you can see from this perspective, from far away, that that runner is running through a very smoggy city. But the runner in the moment, in their peripheral vision or their forefront vision, they don't see the smog. And the same is true for the culture that we're surrounded by. We all live and breathe diet culture. It infiltrated our medical system, our graduate schools, it influences everything. But it's really hard to be aware of its influence because it's surrounding us. Next slide. So one way to think about this is poodle science. So if you imagine that poodles ruled the world, all the dog world, and they said to all dogs, hey, you guys have to look like us. That's comical because we know that no amount of dieting would cause a bulldog to look like a poodle or a mastiff to look like a poodle. And no amount of weightlifting or change in habits would cause a chihuahua to look like a poodle. And it's a good analogy because it's comical to think about, but the reality is we apply that logic to humans. Next slide. And bodies change over time. So not only do we all have a genetic diverse array of bodies, but we also have bodies that change. And most of us were prepped for puberty, whether it's by caregivers or at school. And the message was, hey, your body's going to change. It's okay. But that was the end of the message. Whereas what's really true is, hey, your body's going to change as you age, as you go through health conditions, different life transitions, it ebbs and flows. That's the reality. And it's really diet culture to think that we should always look young and skinny and healthy and things like that. Next slide. So given all of this, I decided to work with my colleagues to rewrite our nutrition goals for patients in our clinic. And our goals are for our patients to have a basic knowledge of healthy nutrition and to be able to detect diet culture's false claims and advertisements, to learn how to tune into their internal body cues, which is really no small feat, especially in the world of CF. And to motivate behavior change from a place of internal values. So not external, not culture, but internal values. And a lot of curiosity in there. And to really uncouple weight and personal worth. And it's just so important to note that this is a very long and messy process. And when people really dive into it, I fully expect this to take 2 or 3 years of kind of wading through the muck to figure out how to get to the other side. Next slide. And some of the tools that we use in clinic that we can talk about tonight that you could start using right now, we focus on mindful eating exercises. So that's using all 5 senses when you engage in eating food. And usually the best time to do that is the first bite, whether it's a treat or it's a meal, is to really engage all the senses. To move from internal values. So if you print off a list of values, you can circle the top 1 or 2 that you feel are really important for your life, and then get curious and ask, what would it look like if I ate from this place of value, or if I moved from this value? How would that change my habits? We also work with the hunger fullness scale. So we look at hungry, 0 out of 10, starving, up to stuffed after Thanksgiving, 10 out of 10. And we help people look at where they fall on that scale throughout times of the day and the choices they make accordingly, and just get really curious with what's going on. We also recommend to everybody to do a social media cleanse or a fast. Like, forget about the cleanses and fast for food. Let's do it for social media, because that is where diet culture and a lot of nutrition misinformation lives. And then we also encourage our patients to explore narrating their own body story. So a lot of people with CF have had their bodies kind of explained to them and told to them by the medical system. And it can be really empowering for people with CF to say, hey, this is actually how I've experienced my body throughout my life. So those are just some tools that we can chat about tonight and that we also use in clinic. Next slide. And then I wanted to mention 2 other things, because I always am asked this question. So a lot of people say to me, can you describe intuitive eating? And the way I think of it is you have your body needs. So maybe you just got home from work and you're starving. So your body needs some food. Then you have your nutrition knowledge. So you get home from work, you're starving, you see a bag of M&Ms and you know, okay, that's going to give me some sugar, but maybe not a ton of protein. I might crash after that. And then you have your circumstances. You get home from work, you see the M&Ms and you know, there's nothing else in the house. This is the only thing I got going right now. So intuitive eating is really taking all those factors and meshing them together. And it's not a perfect, clean process. Next slide. And then the one last thing that I think is really important to mention are social determinants of health. So often we're told that health is not only a moral obligation in our culture, but also that it is entirely within our control. But the reality is health is not entirely within our control. Social determinants of health impact about 75% of our health. So that's things like genetics and biology, the medical care we receive, the physical environment that we're in, social circumstances. And then it's really about around 30% of our health is impacted by our individual behaviors. And so it's not to say that our individual habits don't matter, but just to keep in mind that there's so much going into the picture of health. And with that, I will close and turn it over to our next speaker. Thank you.
Hi, everyone. As Shelby said earlier, I'm Janeil, and I'm an adult living with CF, and I'll be sharing a little bit about CF and nutrition. You could go to the next slide, Shelby. Thank you. So first off, a little about me. I'm 32 years old. I'm married and a mom to 2 little boys. My eldest is 5, Fen, and my youngest, Shelby, is 1.5. I was diagnosed with CF at the age of 4 due to just your typical GI issues. And as part of my CF, I am pancreatic insufficient, and I also have CFRD. So when I'm not doing like mom things and CF things, I like to do, I guess, grandma things. I like to read books and drink coffee and garden. Next slide, Shelby. Thanks. Okay, so for work, I have the unique experience that I get to share about living with CF as a community health leader on cystic-fibrosis.com. And there I get to write all kind of different topics pertaining to CF and connect with the CF community, and I really enjoy what I do. So Kelly brought up this idea of a personal body story, and my personal body story encompasses a lot of different stages and seasons of life. So for most of my life, I experienced the traditional CF nutrition issues like poor weight gain and poor weight maintenance. Once we decided to start a family, I had to work through nutrition challenges surrounding pregnancy and breastfeeding. And then Trikafta entered the picture, and everything I thought I knew about nutrition was flipped on its head. And then finally, the latest stop in my body story is being a mom and experiencing the effects of that on my nutrition. So to begin with, I very much grew up in this eat whatever, whenever you want era of CF. There was a huge focus on numbers and eating as many calories as possible. It didn't matter where those calories came from. But despite that, I still was considered nutritionally high risk. And if you're like me and you have CF, the picture below is probably very triggering. Scandy shakes, Carnation Instant Breakfast, all those weight gain shakes were very much encouraged and kind of pressured and pushed on us, and it seemed like they were the answer to everything, when in reality they weren't. And I always felt that the focus on numbers was more harmful than helpful in my case. And because I felt like I was letting people down when I failed to gain weight, it put a lot of pressure surrounding my weight and disappointment. And I never, ever reached that BMI goal of 22 for women with CF, even when I was pregnant. So I didn't feel like that body type was something that was very feasible for me. Next, I had to work through unique challenges, especially with my first son when parenting was less common with CF, surrounding CF and pregnancy and breastfeeding. So being a mom with CF is absolutely amazing and so special, but quite a challenge nutritionally. I carried 2 pregnancies that were very different from each other. My first, I gained weight beautifully. I was on Orkambi at the time. And then my second baby, my Trikafta baby, I really struggled to gain weight during my pregnancy. Each of those experiences was very different. And I was able to breastfeed past a year with both of my boys, but I quickly learned how calorically demanding that process really is. And probably to much of the chagrin of my CF team, I was very thin during the time that I was breastfeeding. But each of those experiences have involved a huge learning curve for me about managing my nutrition, growing kids, and caring for my kids. Next, Trikafta entered the picture, and everything I thought I knew about CF was turned on its head. When I started Trikafta in late 2019, I gained 10 pounds in the first week I was on it. After 6 months in, I really had the stability that I needed to unlearn some of the disordered eating that I had picked up. And for the first time in my life, I was able to practice more of like an intuitive eating way of going about food. I was able to eat more fruits and vegetables. And because I wanted to, not because it was something that was being forced upon me, I had more exercise tolerance as well. And so if you look at the two pictures, I don't know if you can tell, but I can definitely tell. Before Trikafta, I was very thin looking. I looked very frail. And then after Trikafta, you can see that my body just looks healthier, stronger. I had more muscle mass on my legs, and there was a big difference. Lastly, the current stage I'm in is motherhood and managing the demands of that versus the benefits of Trikafta. And so my weight and my nutrition reflect that lifestyle right now. Kids keep you very busy. A 1.5-year-old and a 5-year-old are very busy. And CF also keeps you very busy. And my nutrition has once again become something that I need to focus more on. And I've had to ask for more support recently, actually nutritionally, and focus on calories again. But I've also been able to take the lessons that I've learned from being on Trikafta, that it's important to listen to my body as well. And so overall, I've really learned that thinking about my CF and nutrition as a personal body story, as a narrative, is a good reminder that I will always be adapting and learning, like many things in life. Thank you.
Oh my goodness. All of you guys, thank you so much for such great information jam-packed in there, and also a look into your life, Janeil. Before we dive into our small panel discussion that we're going to have to pivot a bit with, I just want to give a quick look on why I was so excited to moderate this session. I have a little collage here of photos of my life, and growing up, my CF was mostly GI issues similar to Janeil's. Overall, I was relatively healthy, and I just managed with really only needing my enzymes in my early years. My parents weren't involved really with the CF community and fundraising and all of that in the foundation because they honestly felt bad that I was healthy. And they didn't want somebody who had a very sick child to feel the way that that comes with all of those emotions. You wouldn't know that I had CF just by looking at me, and it was sometimes really hard to deal with on my bad GI days solely because I never looked sick. So people didn't react how I needed to in those years, and it wasn't an issue until really my early 20s. I didn't have much lung involvement at all until my mid-teens and older, but I did deal with a lot of body image issues due to being taller than some in my grade and just other normal teen situations as you're trying to find your place in the world. Throughout middle and high school, I had a lot of issues with distal intestinal obstruction syndrome, which is DIOS, quite often, along with as I got older. And I had a lot of food intolerances come up, which caused a drastic weight loss and strain on my body. The stress from all of this, we think, triggered a lot of autoimmune issues, increasing lung infections, and finally, we now know that celiac was triggered and was at play. To go from feeling and looking one way to the complete opposite was not only hard physically, but mentally as I was getting into adulthood. I loved that during the presentations, the panel touched on each of us kind of having our own body story and just a look overall, because it's absolutely true, and it can be so difficult in different stages of our lives. I honestly don't have a ton of photos from the last decade of my life, and it's mostly due to how much that I didn't like what I saw in the mirror, which I'm sure many can resonate for one reason or another within this community and in our journeys. There's one photo that I'm showing that I now treasure. You can see the drastic change in my photo at 25 years old from the previous ones of me and even now. I only took that because one of my best friends was trying to cheer me up on Snapchat prior to me needing to get my G-tube in 2015. I was so sick and I was so unhappy with myself. I call it the spark within my eyes. It truly just was not there in those years. And I'm beyond thankful for those who stood by me and helped me feed that fire within my soul to just keep going. Some need that mental break to heal, but I'm one of those that needed their people to help as much as a crutch just to wake up every day. I had to advocate for myself and for my body to truly just survive as I battled getting a G-tube and it not being the magical fix that it was said to be. Since dealing with all of these issues, I have made it one of my big priorities in my advocacy efforts to help those who are dealing with similar phenomena within their health journeys. We're truly all fighting different nutrition battles within our own spectrums of health within our bodies. And I love that the panel here today can hopefully give some insight, some updates on research, and also help with answering all of your questions, hopefully. Totally did not mean to get sappy as I wrote this and everything, and even reading it now. But I'm just so glad that we're all here because we all have such a purpose in life. And I hope that things like this conference can maybe help somebody else who's currently dealing with similar things to what I fought through. I don't know if we should take a break right now and dive into things, or we can just jump in and maybe just do one question for the panel. And I think it's just really important to maybe touch on, what do we do when our doctors just want to focus on those numbers? What do we do when we need to advocate for ourselves and they're not thinking this way? And I want to bring the panel back on, and Senthil, maybe jump to you first on what you feel is a great option for this.
First of all, thank you, Shelby, and thank you, Janeil. You both.
Oh, your microphone's not picking up.
Are you able to hear me now?
I kind of hear you.
Thank you so much, Shelby and Janeil. You guys just bring a different perspective. Like the other conferences I have presented, it's mostly just the scientific community or the clinicians and kind of more just preaching within the choir. Whereas the hearing from patients, we learn so much. It's just based on how we say academic learning, research learning. So this is kind of this for to be effective, to bring effective outcomes. I think it helps us a lot. Thank you for that first. So it's a very important question you brought up. So my perspective, so why clinicians are focused on numbers. So I kind of alluded to my presentation. You see a big difference in improvement. So everyone gets positively reinforced by that, and then they are obligated to do something. But I feel practically, I have to say that I changed my practice or my approach in the past 6 years, and it keep on changing, kind of reflecting what we kind of know, what's the landscape of CF, where it is going, things like that. So the change is inevitable. So sooner or later, I'm going to give you a positive, optimistic message that all clinicians will be slowly respond to the clinicians are very research focused. So the more research we give, more we try to convince, the change will happen. I whenever we go to NACFC, I see a big drastic difference for the past few years. Most of the when I started 6 years ago, most of the topics will be focused on undernutrition or malnutrition. Few of them we just started talking about the other end of the spectrum, the overnutrition. But then in the last NACFC, there are almost equal representation, and today is such an incredible day that Trikafta was approved for 2 to 5 years. So I kind of feel the moving forward, there will be less and less discussion, or I wish there will be less and less discussion on undernutrition and more focus on more kind of healthy kind of lifestyle and kind of those things. And then despite everything, having said everything, if clinicians are very focused on number, which means that there is some communication problem likely, either the message may not be translated well, things like that. So I would recommend that patient to be a self-advocate and kind of speak up. And oftentimes, even within the clinician group, sometimes most of the time we don't agree among ourselves, which means that's the other beauty of teamwork. One person kind of brings another kind of version to the other person. So it helps us to see kind of just ask ourselves, are we doing the right thing and things like that. And then for patients, I would say that find some advocates for you. It could be anyone. It could be a pharmacist. It could be a nurse coordinator. It could be a research nurse. It could be a respiratory therapist. Identify those and feel free to give your message, which some patients I have seen that when we go with the MD hatch, kind of for some reason we there is some inhibition. I can feel that. So in those situations, what I do is I tell my social work or my dietitian or my nurse to go and kind of to help us, like help both me and my patient to be a like effective bridge and get more history, things like that. So self-advocacy, finding a good patient ambassador or like a champion. So those kind of things. But then the message is like, I think change is inevitable. So sooner or later we will move towards like kind of more, as Kelly and Janeil alluded, like more kind of like more functional outcomes rather than more just focusing on numbers. And I would like to also ask Kelly, since you are managing adults, um, I think like here, especially the weight management, like more overweight issues started first in adults, and then now kind of like we're also started seeing in children. How do you approach this scenario?
So in terms of focusing on numbers, is that what you're thinking, Senthil? Yeah. I think the first thing to think about is that clinicians are changing too. It's a changing world, and it's been a big shift for all the clinicians. For anybody that's listening, that's feeling frustrated with their team, I hear you. It can be really hard, and especially when clinicians are wrestling with change and trying to wait for new research, it can be a really tricky time to navigate things. In terms of if you're a person with CF and you're feeling really frustrated that you feel like your team is focused too much on the numbers, one suggestion I have for you is actually twofold. One is to share how it impacts you. So to say, hey, every time I come to clinic and you weigh me, I dread coming. That's really important for your care team to hear. And then the second one, if you're feeling up for it, is to offer a solution. So you could say, hey, I dread coming. It feels awful. Is there a way that we could just weigh me once a year? Or I could turn around, or we don't have to talk about my weight. And what I want to say about this is, even if you don't get a response in that moment that feels encouraging, know that your care team is thinking about it. So I had a team recently reach out to me and say, hey, Kelly, we're having patients avoid visits because of weighing, and we don't know what to do. So they were hearing their patients, but they were still kind of lost in the flux of change and reaching out and trying to get answers. So keep speaking up, and know that your clinicians they're coming from a good place, but they're also confused too. And I will say it takes a long time to shift views. So most doctors go through medical school, and that is a very weight-focused training. And it takes a lot to start looking at the research and shifting our views on that. And within my own team, it's taken 2 or 3 years to have our providers think a little bit differently beyond just weight. And usually that's spearheaded by myself and my colleagues pointing out, hey, you know how you said their weight was fine? Their diet is terrible. And it's like exacerbating these other symptoms. We have to point that out over and over. So change is coming. It's really slow. Voice your frustrations.
I love that. And it's so good to hear that the teams actually do listen to us, even in hindsight. Emma, do you have anything that you maybe feel is good to weigh in on, or? No. I don't know if that's a pun or not, but
no pun intended.
Yeah.
No, I agree with everything that Kelly and Senthil shared. Times really are changing, and what we need are more people to advocate for the care that they want to receive. And the few care team members who are advocating for this type of change is really important. But when it comes from the voices of people living with CF, that's really when the change will occur.
And I would add one more thing. I was very fortunate to be part of a position paper focusing on nutrition. Most of you might have seen the draft few months ago. So that will be on print anytime soon, like in few weeks to few months. That also will help a lot of the clinicians to kind of like whatever we are discussing, that's the same thing. I was very fortunate to be part of that. And then working with other experts, it's the same thing kind of resonates again and again, that will definitely help a lot of the clinicians to navigate this complex issue.
I think that's really important, and I will be interested to see that come out. I know we're kind of a little off kilter here time-wise, but I'm going to abide by the rules and take a 5-minute break. And then we'll be back here for about 40 minutes or so, having a more interactive Q&A where we can bring some of you guys on camera if you want. So please submit your questions into the Q&A tab, and we will try to answer as many as we can. If you'd like to come on video to ask your questions, we are absolutely happy to bring you on, but don't feel pressured. You will click on the little blue tab that is on the same screen as us on the panel as you are on to request. And as we bring you on screen, we'll let you answer your question, get a feel for some answers, be able to converse a little bit, and then we'll move on to the next person, giving them your place and switch out. So go grab a snack, a drink, whatever you want to do, and meet us back here in 5.